Thank you. So thanks to the organizers for inviting me here, but also thanks to you all for being here so late into the evening. All right, so this is an abstract that I presented at CROI, and this will be an updated analysis of it. So in terms of background, I think everyone here knows long-acting cabotegravir is the first complete injectable antiretroviral regimen approved for individuals who are virologically suppressed. We know that data on efficacy, safety, and outcomes for persons receiving long-acting cabotegravir during pregnancy is limited. And sort of to couple with that, we know that pharmacokinetic data as well as safety data from the time of FDA approval of a drug to the first published studies has a median of 6 years. That's been shown now in 2 studies. So the objective of this analysis was basically to evaluate viral suppression rates, perinatal, neonatal outcomes among persons with HIV who are exposed to long-acting cabotegravir during pregnancy. And as I mentioned, this is really the first case series out there to describe this. This was presented at CROI, abstract numbers there. This is updated. And just to show you how much of an interest this has, and I'll bring this up at the end. So we presented 23 at CROI. So from March till we submitted this abstract, I had another 8 added to the series, and I have another 6 or 7 waiting to be added. So people are very interested in this. So we performed a multi-center retrospective chart review, and I highlighted retrospective because one of the most important questions I got asked by everybody who came up to the poster was, do you have PK? So the answer was no. It was retrospective. I'm going to talk about next steps at the end. So these were persons in the United States who had received and been prescribed long-acting cabotegravir at any point during the pregnancy. It's from January 21, and I amended my protocol to April 2025, and it'll be amended again to version 3. All data, including infant outcomes, so they need to have 4-month RNA testing to be included in this analysis. If you had none, we wanted to have a complete data set for you. We collected multiple variables, which you see listed there. And again, for the sake of time, there were only 10 minutes. I am only giving you a snapshot. There were so many more, and I think this will become important. Everyone's going to want to hear much more about the virologic outcomes. I know them up here, so if you have questions, I'm happy to answer them. We collected this through REDCap and really used descriptive statistics to describe. So let's look at the demographics of the population that we collected. So median age was 29. Majority were Black or African American. Majority, 90%, were US born. I think important to know that 52% had previous NNRTI experience, and we actually collected which were the NNRTIs. So my first thought was it was all efavirenz. It was actually more rilpivirine, and then as well as efavirenz. You can see the gestational age at their first prenatal visit, which was 9. And for many of you, that may not mean anything. For myself, who takes care, most people are not presenting pregnant at 9 weeks. They're presenting 12, 13, well into the 20s. So something about this group that they all had early prenatal visits. You can see their BNI, about 40% had perinatal acquired HIV, and you can see the listing of comorbidities down there. So what I did for the purpose of this, it makes it a little easier. I broke it up by those who started cabotegravir prior to pregnancy and those who started during pregnancy. I don't have it in here, but I have it in tables that I will, with the manuscript, will be put into the supplemental material. I think it's really helpful to see everything in a table format. So what you see is that 23 or 74% actually started cabotegravir prior to pregnancy. You can see most of them were on bi-monthly. And when you look at the switch, so 30% switched during the pregnancy. So they became pregnant and then actually switched off. All of them switched to co-formulated FTC, TAF, BIC. And the gestational age at switch was somewhere, and it was a median of around 22 weeks. And then long-acting cabotegravir that was changed, so 3 of them changed the dosing. And as you can imagine, most went from bi-monthly to monthly. And so really the summary of this is the majority of people were exposed at conception, most received bi-monthly, and then again, those 3 actually changed to monthly. To me, the more interesting one is those who started during the pregnancy. So when you look, there were 8, and this is up from 3 from the CROI analysis. All of them were started on monthly. No one went to bi-monthly. Everyone was started on monthly. And you can see their prior ART use. Most of them were pretty simple. When you look at that last one, this was, and again, this is where the tables actually really are helpful when you look. So a lot of the people you can see were changing regimens. They were adding new ART, all the things we learned never to do. Don't keep adding if they're not taking it. And the viral loads were staying exactly the same. And then they actually started very late during the pregnancy, some down into the 30, 35 weeks range. And again, here the switch was somewhere around 22 weeks. It was a median. So again, looking at those who started during pregnancy, most started in the second trimester, and again, all received monthly dosing. I just want to quickly show you the way we did this for this analysis, but I know everyone's going to hit me with a million questions, so I'm going to explain it first before you do. So here we're looking at sort of a categorical breakdown. We went less than 20, 20 to 200, 201 to 1,000, and then or 999 greater than 1,000. We actually have the number. So I did it as a continuous variable as well as categorical, because again, you would say, well, if someone had less than 50, where would they fall? And so people really enter data, because again, remember, this is not a monitored study, people are entering. So I thought, rather than trying to go back and track everyone, let me collect both. So that way when I went to put it together, because again, depending on which assay you use. So if you look here prior to pregnancy, 75% were actually less than 20 copies, and then you can see the breakdown there. Interesting enough, there were 5 or 16% that have viral loads that were greater than 1,000. When you look at delivery, and again, we did collect viral loads throughout the pregnancy, I just chose to give you the initial and then at delivery. You can see that 81% at delivery were less than 20, and in that 22 to 100, you add another 13. So I think that's where it gets misleading. So 94% had a viral load less than 200. When I broke down that, most of them were in that like single digits. So they were around 40, 50. So in my opinion, you know, they would be considered undetectable. And then there were 2 that had greater than 1,000. And as I mentioned, why were there 2 1,000? They actually started long-acting Cabotegravir really too close to delivery. So again, high rates of suppression, 75% at baseline, using that less than 20, 81% at delivery. Very few had that viral load greater than 1,000. How about the outcomes, delivery and neonatal? So majority were live births. There were spontaneous abortions and a stillbirth. Most had 50-50, not most, so 50-50 vaginal versus cesarean. And when you look at the indications for cesarean that we collected, most of them were for obstetrical reasons. So they were not for viral, they were not for, due to viral load. All of them had viral load data, all 31 were HIV negative, and then interesting enough, 16% were actually breastfeeding. So in conclusions, I think this preliminary result shows that long-acting Cabotegravir in pregnancy, again, most started prior to conception, resulted in high rates of viral suppression and normal birth outcomes, keeping in mind very small numbers. So further research is needed to validate these findings, evaluate the pharmacokinetics and safety. And I just want to bring up too, I think Natella brought it up, so Impact 2040 is going to look at the PK. The other thing to note is for the antiretroviral pregnancy registry, it's important to continue to collect data here. For those who may not know, so whoever's going to IAS, there'll be an oral abstract on Cabotegravir injectable. There's only 42 first trimester exposures, but that will be presented. Rilpivirine we have due to oral rilpivirine, and there's over 800 first trimester exposures. So Cab will pre-present it. So next steps. So I got a lot of, as I thought it was one of the most interesting things to have a poster with a sample size of 23 and multiple questions and emails, and people were just standing there. They were very interested in this, and as I say, multiple people have reached out to me. So the next step is to convert this to some sort of observational cohort where I can collect data both prospectively as well as retrospectively, which I think is really important. The other thing is to continue to recruit sites. So if anyone here knows anyone, please send them my way. My email will be at the end. Right now I have 17 sites, which shows you the small numbers we have. Most sites had 1. I think our site had the most. And I have 7 now who are waiting, who have patients that have not delivered yet and they didn't have those birth outcomes. So this number will continue to grow. And then the other thing would be Kim Scarsey and Courtney Fletcher have reached out to me about whether or not we can contribute a sub-study in this and collect some pharmacokinetic samples, which I think will be really great. And again, as I mentioned, there are those who have complete data evaluating retention and care and virologic outcomes 3, 6, and 12 months postpartum is the plan that I have for hopefully next CROI to see if there was a difference between the two, keeping in mind all small numbers. I want to acknowledge all the people who contributed to this across the U.S. and the list just continues to grow, and I thank you for your attention.